Welcome, and thank you for joining our webinar today. I'm Blake Baucom, the Director of Sales for Osteogenics. Our speaker, Dr. Gallo, has prepared a great presentation, and I think you'll all really enjoy getting to hear from him. We want today's webinar to be as interactive as possible, so you'll see there's a question and answer button on the right side of your screen. Please use that to submit any questions that come up during the presentation. Then at the end of today's webinar, we'll have some time for Dr. Gallo to answer the questions that are submitted. You will also be emailed a survey after the conclusion of today's presentation. Once you complete that survey and submit it back to us, an email with your CE certificate will be sent to you. Now, for the more important part, I want to introduce my friend Dr. Pier Gallo. Dr. Gallo received his DDS in Colombia in 2002. He then completed his specialty certification in periodontics at the Universidad Latinoamericana de Mexico in 2005, as well as the fellowship in implant dentistry at the Universidad de Miami Miller School of Medicine in Bogota, Colombia, and that was in 2012. Dr. Gallo is a national and international lecturer on periodontics and advanced surgery, soft tissue, bone regeneration, and dental implants. He has been a professor at multiple dentistry and periodontics programs and universities throughout Colombia, and he has been the scientific director for the Training Institute for Development in Oral Implantology in Colombia since 2015. Dr. Gallo, my friend, thank you so much for giving us some time. Looking forward to hearing the presentation today.
Thank you, Blake. Thank you for this kind invitation and for your impeccable presentation to me. So thank you a lot. You can sit and listen our presentation. I'm in Bogota right now in Colombia, and I say hello to everybody who is connected and people from Colombia who is connected. Thank you very much. I hope you enjoy this presentation. Let's talk about guide bone regeneration because I choose this topic of collagen membrane because there's a lot of misunderstanding of what clinical case you can use collagen membranes instead of Teflon membranes or mesh or blocks or Curie. So there's a lot of techniques and the best results that you can get is when you apply the perfect technique for the clinical case. So in terms of talking about GBR, is a bone regenerative technique that uses physical means such as barrier membranes to seal the anatomic space that the defect has and avoid the penetration of the soft tissue, leaving the space to the plug that is going to be the regeneration potential and start building bone. So you have to exclude the cells from the tissue to the bone. It's very easy to understand, and there's a lot of clinical situation that you place the connective tissue on top of the membrane, and above the membrane, there's a plug, there's a graft, there's a torsional bone, and everything is gonna heal perfectly. There's a lot of literature talking about that, and says that horizontal augmentation with blocks, with particular graft, with different type of graft, different type of membrane provide the best results. So is this predictable? Of course it's predictable. If you can make a very good technique and take all the steps and you do it very good, you can have these results of time of augmentation horizontal bones. So if you only follow the principle that is you have to maintain the graft with immobility, you have to release the flap enclosure without tension. You have to use a membrane. You have to tag the membrane. You have to find the stabilization and the fixation of the membrane to get success of time of volume of the bone that you need. There's simples. There's two types of defects. Okay, two types of defects: horizontal defects and vertical defects. It's that it. There's no more. So we're gonna discuss today about horizontal defect because that's the type of defect that I always use a collagen membrane. We're not going to talk about vertical augmentation in this meeting because I don't do vertical augmentation with collagen membranes. And I'm at the end of the presentation, I'm going to explain why, because there's a limitation of these type of membranes. So we have to talk about that. So horizontal bone augmentation is the needed of gain horizontal volume to place an implant and rebuild anatomical situation that leave a crown with supported by an implant with a perfect aesthetic on the mouth. So this is an horizontal defect, okay? You have a palatal wall, but you don't have volume. So is this a vertical defect? Of course not, because you missed the buccal wall, but you still have the palatal wall. So that's going to be regenerable with a collagen membrane, so you don't have to use another situation. There's type of bone defects when you place an implant, they cause fenestration, that you have a little bone. I don't think, can I have, Steve, if I move anything, I can show anything, I can explain anything or not? If I move my mouse. No? Okay, perfect. There you go. So we have fenestration that you can see the bone, there's a bridge of bone between the buccal wall, and you have the dehiscence. Okay, it's like missing the buccal wall from the apical part to the incisal part. That's two type of defects. So the goal of all this reconstruction, regeneration, is that there is a 360 degrees bone around new implants. You have to rebuild your ridges because you need that your implant have two or more bone around it, because on time it's going to be some resorption, and we cannot have implants with bone resorption and threats exposures and filtration of the bacteria, because it's going to be a disaster. So we have to rebuild amount of bone to avoid failure of the implant. So in that type of surgeries, I use collagen membranes. My ideal membrane is have to be resorbable. Okay, I remember the first time that of a classroom that I did in Brazil. The doctor said, "Is it really that the collagen membrane is 100% resorbable?" Because he explained to us that the membrane got integrated in the soft tissue, so it's not 100% resorbable. But it has to integrate. It has to be a collagen. I prefer collagen because the inflammatory response is very less. It has to be easy to handle because those techniques are very difficult to do it. So you can imagine if the surgery is difficult and the membrane is difficult to use. So it's more difficult the surgery. So it has to be easy to handle. Have to be no memory on the membrane. You can see a picture that you wet the membrane and the membrane falls down. It has no memory. It has to be elastic to try to rebuild the famous sausage technique that Professor Urban taught us for a long time ago. Has to be ability to be fixed because the sausage have to be fixed with the membrane. And if it's possible that the membrane has a slow resorption, but in terms of resorption of the membrane, I don't care how many weeks resorb the membrane. For tell you the truth, I don't care that. So let's talk about the different type of membrane that we have on the market. We have the cross-link membrane that has very good properties. It's not a bad membrane, but in terms of fixation, the membrane is not so good. It's not elastic. It's not elastic, so you cannot do those techniques. But it works, and some studies says you can grow bone on it. But in terms of membrane, it's good. It's good membrane, but it's not to do the GBR technique that we know and we call it as a sausage. So we have for that technique the non-cross-link membrane. It has this elasticity. It's a very it's a little bit thick and has a good quality about fixation that you can place the pin or even a screw and the membrane don't rip it off, you know. So it's a good type of membrane. There's a systematic review comparing both membranes, and he said that they can achieve volumetric bone gains with no statistical significance between both membranes, but the tissue integration and the prosperity complication, the results suggest that non-cross-link membrane presents better results. In my experience, I only use non-cross-link membrane. In terms of graft, because we need graft. I prefer a graft that has slow resorption, that maintain volume. I love and I prefer small particles, less than 2 millimeters. I don't like too much the big particles, even is that for sinus augmentation, but I do a lot of sinus augmentation with small particles. I don't see any difference. I have to be animal origin because there's a lot of publication of that and that support of dentistry based evidence um, um, surgeries, and it has to be osteoconductor, so it works like a scalpel. Um, the best materials, the best graft that we have is autogenous bone. There's no question about it. It's autogenous. It's from the same patients. It's a gold standard. It has light cells, growth factors, morphogenic proteins. It's osteogenic. It's osteoinductors. I mean, that's the best graft. Maybe we can mix it, or you can use it alone, or you can mix it. Okay, but one little 3 millimeters piece of pin, it's very important to do this technique. You cannot do that technique with suturing the membrane, placing like that, and now place everything, or place a little rough membrane that resorb very slow. No, you have to secure the membrane with those pins. That was, I guess, the first publication that comes from Professor Urban that says, look, guys, you need to fix the membrane in terms of get volume. Then he reinforced that technique in the second publication when we that year we learned how to do this technique from himself. So I'm going to show you a clinical case because you all want to see clinical case, clinical reality. So this lady patient is like 23 years old. This is a situation. It's lack of volume in vestibular. We can see the CT scan. We have the nasopalatine nerve. We open the flap and we notice that the most lack of bone that we have was on palatal, and the implant goes in palatal. So you need to grow bone on palatal also. So we took a lot of autogenous bone from the ramus, a lot of autogenous bone. We milled that bone with a bone miller. Look at my pretty face when I do that. It's very hard to do that. It's very hard, but it leaves very particle, good autogenous bone. I love a lot of scraper, but in this situation, I want to use 100% autogenous bone. So I scrap a little bit and then took the trephine bones. And I placed the membrane anterior to the nasopalatine. The nasopalatine is the nerve that a lot of people want to destroy. You know, everybody talks about you open the nasopalatine, you take the nasopalatine out, it doesn't matter, rebuild that hole, fill that hole with biomaterial, and you can, I mean, the patient doesn't even care or feel the postoperative complication about that is nothing. I like to preserve the nerve. So I moved the nerve a little bit, like I can show you here. I push the nasopalatine nerve to posterior and place the membrane anterior to that nerve and place two pins to get stability. So you can see the membrane, how you can stretch the membrane and start to feel palatal and over contour our ridges. You might say this guy is crazy because that's a lot of bone. Don't get too excited because there's a lot of systematic review and meta-analysis that speak about regardless of the material used for bone regeneration, graft resorption will occur. Consequently, overcorrection of the defect should be performed to compensate the resorption. So you have to rebuild. Okay, so you have to put a lot. And you close. I fix in the vestibular area with pins, and I close. The free tension release of the flap and free tension closure is mandatory to have success in those techniques. So this is the over contour of the bone. And then she asked for orthodontics. So she said, Doctor, I want orthodontics now. So I place, this is a very good technique called flow jack, orthodontic system, flow jack. And I guess he's made it, or he's invented by some Colombian guy that start to place mini tubes on orthodontic. And I love it because there's no retention of plaque, of calculus. So for periodontal patient, I have a lot of good results with this type of orthodontics in periodontal patients. So after 1 year, the patient returns after orthodontics, of course. And I thought, I place a lot of autogenous graft, 100% autogenous graft. It's going to resorb. It's going to resorb forever. Clinical cases is not showing that. After 1 year, you can see a lot of density of that autogenous bone, but you still have a defect. So people think that just only treating bone, you're going to do a very beautiful case. You're wrong, my friend. You're wrong, because it's not about just bone. It's about soft tissue and bone. So right now I have bone, and I'm pretty sure you're going to like this video because this is a very pretty good bone. And it's 100% autogenous bone. And we can place the implant, and that's all beautiful. Right? And we place the implant. This is the amount of bone that we have. We place the implant and we wait 3 months to uncover the implants. So I put this stand of provisional. I take a little blur and start to eliminate tissue. I get to the screw. I take the screw out. I place my provisional abutment, and I place the guide that I have for the provisional, for the position of the provisional. I take the provisional glue, I don't know, with composite, right? And I start to rebuild the emergent profile. And it's easy. It's easy because it's all published. It's all published with my good friend Ramon, Jonathan, and Dr. Blythe. It's published that you have to rebuild the emergent profile, and in that same day that I uncovered the implant, I place the provisional, and look 8 months later, how much tissue do I have to work on? So I take the provisional out and see how much tissue in the patient that didn't have papilla, didn't have volume. Now you can see the amount of gum and aesthetic, pink aesthetic that we have. Okay, let's talk about functionality. There's a patient that is not, it's not coming here because aesthetic. It's coming because function. And with those type of ridges, look how thin is the ridge. We do a big augmentation and a sinus elevation, and look 8 months later how much bone we can rebuild. And now we can place implants with collagen membranes. So look the amount of bone, and look the implant placement. 6 implant placement to do a fixed prosthetic. And this is the final result of the prosthetics. and lose the final result. A patient who is coming for function, not only aesthetic, function. And this is the final X-ray. A lot of scenarios I use it when one scenario I use a lot of collagen membranes, and I'm talking about sinus elevation. I love to do sinus elevation. Right now in this area, we all do it digital. So we scan the patient. We know the how much bone, how much thick is the sinus membrane. We can place virtually implants, do the workshop, do the scanning. We place the tube. We organize the implants, where they come out. How much bone do we have? How long it's gonna be the implants? In what type of bone there's gonna be those implants? How much bone do we have to rebuild in terms of leave the implants all around the regeneration tissue? So I hope you can see a 2-minute video of how I do this clinical case, because I wanted to show a video of the surgeries. So I elevate a full thickness flap. I scrap with what I think is the best scraper in the market. It's the safest scraper. For me, is the best scraper in the market. In this case, I prefer to use piezo surgery to do a small delicate window, and I decide to remove that bone and start elevate the sinus. It's very easy with a very good instruments. It's very easy. Sinus elevation is too easy with good instruments. Then with a surgical guy, I start to prepare for the implant, and I have a big collagen membrane, and I cut a little bit, and I gonna take a little bit of collagen membrane to the sinus wall to separate the Snyder membrane to the particles of the graft, because one of situations that you can have perforation of the membrane is when you start packing your graft. Okay, I think it's more available if you can do it with big particles. But I always protect the Snyder membrane. I place my 2 implants, and I notice that I have to rebuild. Okay, I'm placing the screw. I took a lot of xenograft because right now I don't need autogenous bone. Okay, I'm gonna use the autogenous bone to where the implants thread is exposed. I place a collagen membrane. I place 2 tacks on palatal, and then I'm going to use the scrap autogenous bone. I don't mix that bone. First of all, sinus doesn't need autogenous bone. Then for volume, you don't need autogenous bone. You just need a little bit of graft, because you're not going to reopen that flap because the implant is already placed. So I place the membrane. Look how stretched the membrane is. I worked with these Citamatrix membranes for a long time ago. I place these 3 pins to stabilize the graft and do the primary closure. This is the X-ray. Then we design the crowns, and we put the crowns and schedule for a little vestibuloplasty. But look, 1 year, how much stability of bone we have. So there's a lot of techniques that I use with collagen membranes. One is when I do a Curie technique. And this is very trending, because right now there's a lot of people doing this technique. There's a lot of people doing it, and it's kind of like a rival technique between Cree or membrane or customized mesh. And I mean, I think the human being always trained to get in competition. To look who's the best. Who's the best NFL team, who's the best basketball team, and there's always competition because that's the human being nature. So I don't think I don't guess that there's any technique better than the other one. I do both. I do a lot of customized mesh, but it's very difficult because in Latin America there is no customized mesh. So I have some occasion doing to buy it in German and all stuff. But I don't think we can compare both technique because autogenous this split bond block technique, that is the real name, split bond block technique from Professor Curie, is the same than blocks. It's gonna resorb. There's gonna resorb. I mean, a little bit more than the particles, and I notice in my clinical cases. I notice. I hope that the sound is good because there's an ambulance over here. Steven, my voice is good? Perfect. So there's a lot of controversy in terms of speaking this technique because there's a lot of people who said that you don't need how do you say, the occlusal wall, that you don't need it. I prefer to place off this particles autogenous bond and place a wall that is a cortical. It's a cortical plate in crystal. I love it. I like it. I do a lot. But sometimes I don't have enough space or enough bone to take from the patient. So I have to use a collagen membrane. Why don't you close, or why don't I close the flap in contact to particle bones? Because there's a lot of soft connective tissue on the periosteum that is gonna enter to the particle bone. And when I open those cases, I notice that the bone is like a jello. It's like how do you say? I'm gonna say that word in Spanish is plastilina. Plastilina. It's like something that the kids start to toy. That's like a play doll, something like that. Okay, that's the same feeling because it's not hard. In those cases that I use collagen membrane, I found a very hard type of bond because the collagen membrane that, look, this is important, don't have to be fixed. I know a lot of guys in Italy that they fix that membrane on top of the Curie technique or in top of the customized mesh or in top of non-resorbable membrane. The only non-resorbable membrane that need uh, collagen membrane is the perforate, the mesh cytoplasm membrane. That's the only non-resorbable membrane that needs a collagen membrane. So you don't need to fix that membrane, okay? You just place a very good, very big membrane on top of that graft and wait. We wait 8 months. Why? Because I think 4 is too early, and I know a lot of people that they're selling this technique, talking about, look, this is the implant placed in 4 months of old or 4 months of post-operative. What is the rush? I mean, why do we have to rush with patients, with clinical cases? I take very serious my profession, and I took a lot of time to wait for bone growth because I need to have the phase of remodeling bone. I don't know if you can see. I have I don't see. I have this slide, but you can see here how much bone has the screw on top. And look The next, look the bone, it's on the side of the screw. So we have that a lot of resorption. So look again. Look the screw that is coming blood from them. That is the screw that is on the middle of the image. So you see a lot of autogenous on top of that screw. That's Curie screw, by the way. And you don't see that amount of bone. It's remodeling. So imagine that you place your implant at 4 months. And then after 4 more months, they're gonna resorb. And you're gonna leave the thread of the implant exposed. That is a big mistake. And you're gonna fail a very beautiful bone regeneration with a very tough, stupid decision of placing early implants. You need to have time to wait for the bone augmentation and bone remodeling. Another scenario, another topic is when you are treating maxillary. I didn't do a sinus elevation here, but what I did is that I took a autogenous block and I released that, and I find out that I just only have 2 plates. There is no more space to take, because that's the same patient that I show you later in the early case in the lower mandible. So you have to use 2 plates. So I prefer to use the thick one on top, and the other one on vestibular. But guess what? I need a third one, but I don't have bone. I don't have more space. Okay, I'm not gonna go to the tibia and take a little bit of autogenous bone. Okay, so I place a collagen membrane. Why? Because I need to exclude the connective tissue from palatal to the new bone, the new graft that is going to be autogenous, because this technique is 100% of autogenous. Okay? I place and I take this collagen membrane, and look, when I'm telling you that this membrane, this matrix membrane has no memory, it's because they fix into the defect in the form that you want. This is, for me, one of the best membrane in the world. And I'm very pleased to still working with this type of membrane. Let's take a look of a CT scan in lingua, in palatal. Look how we rebuild the palatal wall with the collagen membrane. So you don't see, you see a little of cortical, right? Like a natural bone. Look that bone. Steven, did you erase the slices, or did you hide it? Okay, can you unhit it and take me to the slide 60 something? Because I'm perfect. I have very good time, and I really want to show you everything what I prepared. 62, I guess. And take me to 62. Thank you, Steven. So in that typical cases that I use autogenous plate, because I don't like allograft plates. I don't think that there's good best evidence in the world with long-term results that you can assume that it's a predictable technique. So I prefer in this type of a scenario only autogenous bone block. So when I use autogenous bone block, I prefer to cover everything with membrane. Okay, let's take this concept clear. the membrane is not gonna prevent. There you go, Steven. You're the best. Thank you. The membrane is not gonna prevent you to have exposure. Okay, the collagen membrane is gonna prevent you to get exposure. So you have to get very good release flap and have primary closure. And you have, when you have no complication, you're gonna find this success. So this is a vertical defect. And why I'm going to show you a vertical defect? First of all, because I like this case. So, and I do my presentation, so I'm going to show you a case that I really like, and I use collagen membrane in this case. So this is the vertical defect. Unfortunately, this tooth is dead. I have to take this tooth out because I have to take the more occlusal crest to obtain the best regeneration. I've been working for about 2-3 years with this perforated membrane, with this mesh, reinforced mesh membrane with titanium reinforced, and it works very good. It was very good. This is a mixer of 80% autogenous, 20% of xenograft. It's Cetacore. I always said it in Spanish, so I said Cetacore, but it's Cetacore. And on top of this membrane, I use a collagen membrane, a Cetamasys collagen membrane, and it's been tested because recently, out of the oven, there's a randomized control trial when they test membranes without collagen membranes and membrane mesh, Teflon mesh without Teflon membrane, without collagen membrane. So they wanted to try it, which size is grow more bone or less soft connective tissue above the mesh membrane. So it's a very new research, and says that, I mean, you can get the same amount of bone, but in the cases that has no collagen membrane of top of the Teflon mesh, they found a thicker soft tissue and a little less bone. But there's no significant difference between them. I still want to do the procedure with collagen membrane. There's a primary closure. That's the other side, because it has both. I do both simultaneously. I place my membrane. I place the collagen membrane on top. That's one of the one of the cases that I use collagen membrane, and that's the topic of our presentation. That's the follow-up of the clinical case, both without any exposure, without any infection. Thank God, I had lucky, I guess. And I start to do the planning, the digital planning for implant placement, preparing waiting the 9 months for the regeneration to do the implant placement and remove the membrane. We right now I work with a very good radiologics here in Bogota, so I always do everything guided. So I open, look the amount of bone, looks very good for me. There's not a lot of soft connective tissue. I place both implants. Sorry, my mother's calling. And I place 2 implants, and then I place soft connective tissue graft on top of both implants. The other side, I cover everything, primary closer. The other side have a little more of connective tissue. So it's very hard to determine if the collagen membrane works very good, but that soft connective tissue is not a bad tissue. It's not dead tissue. Has a lot of fibroblastic cells, a little less of vessels, but it's very healthy tissue. So you don't have to remove it. I place one implant. I place a narrow implant more than a implant because I had a mistake. I placed the other implant. I place a narrow implant instead of a wider implant, but I don't care. It works very good. So I close everything. This is the situation. So we have bone done, place implant placement done. So we need to work on the soft tissue, and that's the third surgery that I'm going to have. So I do a vestibuloplasty surgery, apical migration of the non-keratinized tissue. I take a little bit of keratinized tissue from palatal, a free gingival graft. I place it with a little less of suturing. I don't do a lot of sutures. I used to do a lot of sutures. I don't do a lot of sutures now. And the other one, I place the other gingival graft. So I took two gingival grafts, one from each side, and that's the healing. That's the beautiful healing of this. I love gingival graft. I think I wake up one day and I see my agenda and I see two gingival grafts and I feel more happy than when I see two vertical regeneration surgeries because I love the soft tissue grafting. I enjoy a lot. This is the other side. Look how much bone, and look how much soft connective tissue. And if you notice, I always, because I'm a periodontist, of course, I always see the tooth next to the defect. I don't only keratinize around the implants. I always keratinize the tissue that has lack of keratinized tissue. And most of the time that you do this type of surgery, you have some teeth around the defect that lost every keratinized tissue. So you have to think about that because you don't need long-term problems with periodontal problems in the tooth around those implants. And look the final result. It looks very good to me. This size looks better. That's very difficult, both when you treat two implants than one. And I think it's a pretty good case, a pretty good final case. That's the other option that we have. Steven, my friend, take me to the last clinical case, please. We have 4 minutes left, and yes. I don't have a slide number because maybe I am. Yes, I am. Take me to the 139, please. There you go. Okay, perfect. There you go. Thank you. So we're back to 2006. I'm sorry, 2006 was 2006. I already graduated as a periodontics, and I have no idea what I was doing. I have my periodontics degree, but I didn't have any idea of do vertical augmentation. And I said, in my ignorance, in my stupidity, I said, okay, why don't we place a screw, like a tension screw, and rebuild that bone? I'm talking about 2006, and place a membrane. And we try to do a vertical augmentation without a Teflon membrane because we have like exposure and everything, So let's take a collagen membrane because our exposure of the collagen membrane is not that bad that the exposure of the Teflon membrane. My friend, exposure is bad in every way you see it, okay? In every way you work on it, exposure is a bad situation. So you have to deal with that. So I tried to get a vertical augmentation with collagen membrane, and look what happened. That you can do. My friend Steven is a message to you. Both you can see the transfers of a digital camera. That's when I transfer to one camera, an old, very old one, to the new ones. So I took this photo and I noticed that the screw was coming out. And it's not that the screw actually coming out of the mouth because the body is rejected it. No, because there's a screw on the bone. It's that the soft tissue migrate apical and didn't care about the screws. And the screw start open on the tissue and get contamination. And the final result is no bone gain, vertically speaking. Okay? So I don't believe in vertical regeneration with collagen membrane, even if you are using tenting screw. I have more than, I guess, 25, I have 19 years of experience of doing wrong. So it doesn't work. And the literature, it's working on that because it says to you, look, when you treat it low vertical defects, you can use a collagen membrane only for 3 millimeters. If you need more than 3 millimeters, you cannot use collagen membrane. So in other scenarios, you need 3 millimeters. For example, you place your implant, you have a little bit of penetration or even dehiscence, but you left the implant a little bit out because you don't want to have a deeper implant. Uh, Even though right now there's a lot of scientifics that research that says that the deeper the implants, you get more platform switching. It's platform switching kind of emergent profile with the crowns and a lot of tissue around those implants. That's a little bit of changes of what we think we know to 10 years, 15 years ago. So we place the graft, we overcorrect, we uncover that, and we rebuild the bone in vertical with collagen membrane. You can do that. Of course, you can do that. But if you're only working with 3 millimeters. So, conclusion of this guy bone regeneration with collagen membrane and particle graft is an effective technique. It's an effective technique. The implant survival rates are simultaneous of subsequent implants are very similar. You can place the implants and do the bone augmentation, or you can do the bone augmentation and then the implant placement. It both works the same. Okay? I have 3 seconds. I'm gonna conclude that horizontal bone regeneration is a fairly predictable treatment with multiple techniques to achieve the goal. Soft tissue management and primary closure helps us to achieve predictable cases. Soft tissue grafts are indispensable to achieve aesthetic in cases of dental implants. So you need to learn how to take soft tissue from palatal. It's not only bone. It's not only the brand of the implant. It's not only the crown. It's bone, soft tissue, emergent profile, very good implant, very good connection that is going to let you a very beautiful aesthetic case. Membrane stability is crucial to the success of the outcome of regenerative treatment. Thank you, Osteogenics, for this amazing opportunity. I don't know who has the record of how many webinars I've done with you guys, but I'm gonna work a lot to win that goal because this is my second one.
Thank you, Dr. Guy. Yeah, we'll I don't know if you need to work on the number of
We'll work on
presentations
that.
on your golf game, but one or the other, yeah, you could work on something for sure. No, your cases are always awesome. It's really cool to see your surgical skill, and then also what I enjoy about your presentations is you're not just showing one technique; it's many different techniques, and you do a great job of showing your kind of learning journey from the time you first started to where you are now. And I know you say that many of these things are very easy. I think people would laugh because I don't think they're all as easy as you make them look at this point. But regardless, thank you so much for sharing your cases here. You've done a great job, and the presentation was really impactful as always. We'll spend a little bit
Okay,
of time
great.
now
Thank you.
with some question and answer. As I mentioned before, we have the question and answer button there on the right side of your screen. So if additional questions have come up, please let me know. We've had some really good questions that have already come in, so we'll start with those. Let me see if I can pull them up here. So the first question is, what's the difference between allograft and xenograft in terms of height gain? Is it a big difference? Do you have to
Yeah.
have both? Kind of speak to the
Yes.
difference between the two different
Yeah.
graft materials.
Nice question. Yeah, nice question. It's very, very important question because we have both on markets in Latin America, in US, in Europe. You need to have license or to have some registration of your clinic to work with allograft. Allograft is from the same the other human being, from other human being, um, and xenography from animal. In terms of volume, um, we're not pretty sure because we have a lack of research on randomized clinical control trials with a very long-term results comparing both. So in Europe, when they do a lot of research, they have a lot of publication on xenografts because they don't have a lot of allografts, you know. So in terms of stability, allograft shows more in terms of volume than allograft because allograft resorb a little bit quicker and replacement with new bone a little bit quicker than xenograph. So in terms of stability, xenograph win that medal goal when you compare to allograft. But both works very good unless, I mean, both works very good if you mix with autogenous bone. The only two techniques that, or maybe three, the only three techniques that you only use biomaterials is sign of lift, ridge preservation, and if you want to gain volume in vestibular, but your implant is already placed. Okay, that's three techniques. But works always if you want to do a vertical ridge augmentation, you have to mix xenograph with autogenous.
Yeah, thanks for the clarification there. That's a question that comes up quite a bit for osteogenics as well. People
Quite
are
a bit.
asking us, how do we blend it?
Yeah.
One follow up there
Yeah.
that I would ask is, what's the ideal ratio for, let's say for a vertical ridge augmentation, what's the ideal ratio of autogenous to
Yeah.
xenograft? And then the same question for
Yeah.
horizontal.
Yes, that's very frequently questioned because we don't know how to mix it. We don't know how because we don't weigh the graft and we don't calculate the volume. So it's very very difficult to get that. A lot of people ask how much bone do I need to a vertical augmentation. That's another very good question, Ian, and I don't know the answer. But in terms of mix, in 2010, in 2011, there's a research that spoke about 50-50. 50-50, 1-1, 1-1 radio. After these 15 years pass, after 14 years pass, they start to use more autogenous. They don't. When I say they, it's the research, the scientifics that do a lot of research about this and clinical surgeries also. I think, in my opinion, they start to see the resorption of the graph in terms of year passing with 50-50 biomaterials and autogenous. Right now, Professor Urban, Massimo Simeon, Sasha Jovanovic, Carlo Tinti, they use more autogenous than xenograph. So they can tell you that they use 70% of autogenous, 30% of biomaterial. I just went to see I went from Professor Maximo Simio in Milan, and what they do is like they take a lot of autogenous and they split it on the half. So you have 50% of autogenous and 50% of autogenous. And then he takes the xenograph and start to let the xenograph out, to spread the xenograph the same amount of every 50%. So he will be one third, one third, one third. So actually he's gonna left with 60% of autogenous and 33% of biomaterial. But there's always more autogenous. That's what I love a lot of Safe Scraper. I love Safe Scraper. Safe Scraper is the best scraper in the world, in the market. Unfortunately, uh, we don't have it in Colombia, but in a lot of countries of Latin America. But that's the work that Osteogenics has to do to
We'll
get
work on it.
more safe scraper. Yeah, of course, we need it. We need it.
Yeah, it's interesting to hear the Italian precision. He wants to make it exactly the ratio that he wants, and I'm sure we're going to have a
Yeah.
new naming convention. We're going to have like the Parmesan technique or something when we're sprinkling the bone particles
Oh,
in there.
really?
But a couple other questions that have come up
Always
here.
is taken with food. Always
It's always with
techniques
food.
are with
The
food
sausage
names.
technique, the
Yeah.
lasagna technique, the sandwich technique.
Yeah,
Exactly.
yeah, yeah. Sandwich
Um,
technique. Yeah,
Here's another question for you, and we'll ask this first about collagen membranes. Does it matter if the membrane touches the tooth?
yeah. No. No, it
Okay, and
is
what about with
matter
PTFE?
that the Teflon membrane, the PTF membrane, you have to leave the membrane away 1.5 millimeters, or maybe 2 millimeters away from the tube, because get contaminated with the sulcus. But collagen membrane, I mean, remember, GBR came from GTR, guy tissue regeneration, and guy tissue regeneration is always done with collagen membranes. So can't touch the tooth. Yeah.
Gotcha. All right, so we've got a few more questions here, and I know we're short on time. If you've asked a question and we haven't answered it, we'll do our best to work with Dr. Gallo and get answers, and we'll email those out for those of you that have asked those
Of course.
questions. I'll ask a couple of
Or
quicker
contact
questions that maybe you could
with
give
our
quick answers
social
to.
medias.
Yeah, social media as well. So here's a quick question: do you use IV sedation for these treatments, especially for the Curie technique?
Yes, I do. Always.
Okay.
Always. That is not a way that the patient says to me, I do it awake. There's no way. There's no way. It's like trying to do a colonoscopy awake. I mean, you don't have to, man. Come on. You know, I mean, you have to.
Uh,
Steven is laughing. Steven is laughing, always laughing in the presentation. But I mean, it's very difficult. I mean, there's no way that the patient has to suffer for this type of reconstruction. There's no way, man. We have to do these techniques with IV sedation. I have the opportunity to travel around countries, and it's not easy for many countries that has IV sedation, and we're very lucky to live in the capital of Colombia, and there's a lot of doctors that can perform an IV sedation. But yes, of course, this is an IV sedation type of surgery. The
um,
Curie, the vertical augmentation also, but one implant, one connective tissue, that is not needed for IV sedation.
okay. Here's another quick question: the pins that you're using, do you leave those in place routinely?
Yeah, sometimes. Yeah, sometimes. When I don't need to reopen, because we have to understand one thing. When you make a bone regeneration, and then with the collagen membrane, and then you want to reopen the case to see the bone, you're gonna you are damaging the bone. You are damaging the bone because you're taking the periosteo out without no necessary. So if you want to damage the bone that you already formed, let's take the pins out. But the pin is surgical. I mean, how do you say surgical blade?
Surgical grade.
It's yeah, surgical grade. So it can be in bone. It doesn't matter really. It doesn't matter. But if the pins are very superficial, very crestal position, and it's shallow, and you can see through the tissue, yeah, you can remove it. But the deeper one, the apical ones, you can leave it without any problem.
Okay, great. I think that's all the questions that we have time for. There's one comment here from your friend Maximiliano Clavero, and I'm going to butcher this because I'm going to try to say it in Spanish. But he says, "Excelente presentación, Dr. Pier Luigi Gallo, nuestro es von urban in Latino America." So he's giving you a big congratulations.
Big
He's very
compliment.
pleased. That's
Yeah, yeah.
Maximiliano Clavero. So
Yeah, that's I think that's one of my cousins. Yeah. You have to be relative to me to speak like that,
yeah, right. Well, Dr. Gallo, thank you so much for taking the time. I know we're a little bit over. I appreciate you spending some time with us to answer these
No,
questions.
I've spent very good time. I needed like 2 hours more, but I know that you want to see the masters and I have to leave you that.
Perfect. Well, one final reminder for the audience. Again, thank you for watching. Just want you to know you'll receive a feedback survey from us here in the next 15 minutes or so. In order to get your CE certificate, you need to fill out that survey and send it back to us, and then that kicks our system into sending you out your CE certificate. So please make sure you submit those to us in order to receive your certificate. And with that, Dr. Gallo, thank you one final time. We appreciate your time, and everybody else, thanks for joining us tonight. Have a great rest of the day.
Thank you.
Goodbye.
Thank you to everybody. Bye.